as mentioned by Lily May, we do have a message from the chairman of the board of APAGE, Professor Chi Long Wee. So,
ladies and gentlemen, I'm Professor Kilon Lee. Thanks for Dr. Rennie Secon's invitation on behalf of the APAGE. I am delighted to be here and welcome you to attend the minimally invasive lecture series for Society Gynecology Oncologists of the Philippines members and fellows in training webinars. There were 15 minimally invasive surgeons from Philippines have trained in APAGE since 2007, and some of them are gynecology oncologists, namely Dr. Rennie Second, Dr. Doris, Dr. Angelito, Dr. Queenie, and Dr. Maneri Mendoza, and some under training. In view of the poor outcome of a leg study, all of us are aware of that because of the performance in surgeons is not standardized in all over the world and in the study. And the standardizations of radical hysterectomy is not widely accepted in all over the world. And the new instrument and the new concept will impact the MIS surgery is not considered in this study. So we know the completions in training and educations of the minimally invasive surgery is very urgent all over the world. APAGE value the accreditations and have hold the credible accreditation for minimally invasive surgery, gynecology oncology endoscopists since 2021. APAGE fellow could apply it online under grandfather law by simplified procedures. We welcome all the gynecology oncologists endoscopists from Philippines to apply the accreditations. I hope the webinar series are successfully concluded and all the participants could absorb the great knowledge from experts.
hello. Yes, now we're here now in the Q&A. So we invite all the speakers and the reactor. Okay, sir, thank you very much. In the interest of time, now we'll try to have a few questions. Some of the questions have been answered already online. So for those at least who want to learn from the answers as well, and what were the questions, you can actually go to the Q&A box. Just click it at the bottom of your screen. Sir, siguro just to kasi nabala na namin kayo, sir, no? So a question na lang from me, sir. The usual, medyo baka controversial, no? People might take it the wrong way, no? But kasi some people think na, like being a laparoscopist, sir, do you think it is parang an inborn quality, or can you teach someone, or can it be acquired? Can you acquire the skill and be like a very or a great laparoscopist?
Well, from my observation, from those who have trained in East Avenue, they have different levels of learning the skills. Hindi lahat pare-pareho. But there are those, even the literature would say, there are those who really are not born to be laparoscopists. There is some parang inborn din siguro yung skills. We do have varied skills. Yung iba, hindi nila ma-perfect yung kanilang fine movement. And those are the ones who may not be really for laparoscopy. You can makikita mo naman na bawat trainee mo. And that can be attested by Doris and Renee sa mga fellows nila. Iba-iba yung level of skills nila in learning laparoscopy.
Thank you, sir. How about Ma'am Doris and Ma'am Rennie?
Grabe si Sir Ron.
What? I'm just asking.
Hindi, si Sir Ron, nakikimam. No, I agree with Dr. TC. No? So, in ESGE, they have this dexterity test, parang screening siya. If you would be still pursuing it, you would be advised na maybe not for you kasi parang kahit na ano pang gawin mo daw na practice, kahit na marami, sabi na, di ba, meron tayong kasabihan na practice makes perfect. For laparoscopy, if you compare it with open, no, it's not just a see one, do one, teach one, do one and teach one. Hindi siya ganun kasimple. And steep na nga ng learning curve. And there are things na kailangan talaga, merong may kamay for that. No? Even in open surgery, mapapansin mo naman, hindi tayo lahat equal. Even if we aspire to do so, with a lot of practice. But there are some na kahit konting practice lang, yan, ang bilis nila makuha yung learning curve. So, kung meron tayong ganun, no, Sir, Dr. TC, no, kung sa PSGE na ganun, so, or for the learning, for the mga training institutions, kung gayahin yung ESGE, kasi yun yung preliminary, you have to show para siyang practical, even before proceeding to more advanced kasi it's for the safety of everyone na hindi na lahat meron ganong dexterity. For dentistry, may dexterity, but I think for surgery, it should also apply.
How
I have
about
not-
you?
Ron,
I've
may
nothing
nabasa akong literature. Sabi, ang type A personality, hindi daw magaling
Pwede sa
for
lap.
Hindi pwede. Naku.
Nabasa ko yun eh. Kasi wala silang patience.
Hindi pala ako type
Kulang.
A.
How about
Okay.
you, Ma'am Remy?
Not ma'am, but yeah, I agree with both our esteemed speakers. And I just want to thank Dr. TC. I really like what you were saying a while ago. I learned something. It's very insightful.
Thank you.
Yeah, I take what you said. I'll imbibe what you were saying. The insights of the most experienced laparoscopist in our society. So I just want to give my thanks that you're able to come. But I have nothing to add. I agree with both the statements.
Okay. Are there any, let's say, out there that will maybe test your movements out there that will help you like improve it at least, or or anyway tell you na okay, I might not be for laparoscopy? Are there anything out there that we can probably test your dexterity?
There's the GISEA program. I think Sir Katja mentioned it earlier. GISEA, it's a series of practical tests. They test your hand-eye coordination. It's timed. It's a pass or fail. I don't know if it can be used to select sino yung okay, sino hindi. But there is.
Mhm.
I think PSGE already started that a few years ago, and I'm trying to do a study on that also about applying the GISEA program here in the Philippines in a training institution.
Okay.
So there is.
Yeah, for those who are not really very talented, don't have the skills of learning very fast. Pwede namang just double your effort. Mag-aral ka sa laboratory. Sa anong tawag nila doon? Yung
Dry
ating
lab.
dry lab.
Box.
Yes, spend more time with learning through the dry lab. Huwag sa tao. Pagtiyagaan mo lang.
Okay, thank you. So maybe we have time for just one more question. I think anyone can ask, but Doris answered this, but I guess it's good now. It's a question from Ferdis Galbo. Principles why pure cutting during colpotomy? Why preferred anterior approach first? Doris, you answered this.
Yeah.
Initially,
So
by-
yung sa anterior, kasi mas siya, yun yung mas nakikita mo. Minsan ang hirap i-retrovert and then you lose already air when you already retrovert, when you do severe anteversion. Pero minsan din, it's a matter, di ba, Sir TC, of convention, of what you have been used to. Kasi may iba, mas nasanay sila to do the posterior first. Kami, nung nag-LAVH kami, pinapauna sa amin yung posterior kasi siya nga yung mas malalim. Dapat ma-reach mo siya. Mas madaling ma-reach vaginally yung anterior. So that's why they make us to the colpotomy posteriorly and then proceed with the vaginal surgery.
Well, yeah, laparoscopically or laparotomy, start with the most accessible portion. Like with the vaginal hysterectomy, it's easier to start from the posterior cul-de-sac rather than the conventional anterior cul-de-sac, dissecting the bladder. Pasok ka kaagad sa posterior cul-de-sac, gupitin mo na, nandun ka na sa cul-de-sac eh. That would be easier.
Okay, so may question ka pa you have anything to add, Renny?
I just want to say that for me, that's why I like laparoscopy is that it's not so dogmatic. I always think that there is a balance between innovation and but sticking to the principles. So there's no one way to do things. That's why I don't like it when people say, do this. This is the only way. This is the right way. There's always so many ways. And as Sir mentioned, there are different approaches. There's single port, there's multiple ports, there's notes, there's robotics. So there's no one way. And I think we have to change our thinking, our dogmatic thinking, for us to embrace laparoscopy, which was born out of a spirit of innovation. So I think that's what I think. When I answer is, should it be this way? Should it be that way? There's no should. It's always can. It can be this way, it can be that way.
Oncology, Hospital da Luz, Lisbon, Portugal. He is an attending surgeon, Gynecologic Oncology Unit, Champalimode Foundation. He is an Inigo ESGO faculty on Introduction to Robotic Surgery. He is now a PhD student at the Nova Medical School, Lisbon, Portugal. He had his fellowship in gynecologic oncology at the Gynecologic Oncology Service, Department of Surgery, Memorial Sloan Kettering Cancer Center, New York, USA. He also had his fellowship in minimally invasive surgery, Changgung Memorial Center Hospital, Linkou, Taiwan. And he had his fellowship in laparoscopic surgery, Centre International de Chirurgie Endoscopique, Clermont-Ferrand, France. Friends, let's welcome Dr. Joao Casanova.
Thank you so much for the invitation. I really would like to say that it's a great honor to be here, and I would like to thank you to Dr. Sikam for inviting me, and it's a great pleasure to have you, to be here with you very early in the morning in Portugal. So without much ado, let me just get my things going. All right, so I think my presentation is going to be complementary to the great presentation that we had before. So I'm just going to talk a little bit of like operating room and setup of robotic surgery. So I have no conflicts of interest, except that I really enjoy robotic surgery. The brief agenda. I'm going to talk a little bit of GYN oncology and robotics, a brief review of the literature, just show you a little bit of the main components of the Da Vinci Xi, which is a little bit different from the SI. The trocar placement for GYN oncology procedures on the Da Vinci Xi, and show you a couple of videos of the docking part. Show what robotic surgery has allowed me to do, and a few take-home messages. So I think like it's important to start by the GOG Lab 2. It was published in 2009. Same oncological outcomes in endometrial cancer of MIS and open surgery. So minimal invasive surgery is feasible, it's safe, it has less complications and better quality of life for patients. So it's safe to say that MIS was established as a standard of care for endometrial cancer by that time. So this was published in 2014, and I just wanted to show you that the authors tried to evaluate how was the movement of outpatient benign hysterectomy in the US from 2008 to 2014. And what you can see is like that as robotic surgery was becoming more disseminated, there was a trend to move the patients from the inpatient setting to the outpatient setting. And that, as you can see on your right-hand side, was basically due to more robotic hysterectomies being performed. So the authors just concluded that from 2008 to 2014, the rates of laparoscopic hysterectomy and robotic hysterectomy both increased. There was a significant shift from inpatient setting to outpatient setting. And these findings suggest that robotic hysterectomy may facilitate that shift to outpatient benign hysterectomy, and particularly in patients with complexities. So, but what about our thing, our métier, like the French say? Well, what about GYN oncology? So this was published by my group at Memorial Sloan Kettering. They analyzed 200 robotic hysterectomies, 47% with a malignancy diagnosis and 45% had complex procedures that the authors defined at least some lymph node evaluation, and 78% would discharge on the same day. This was also like an important paper that was published in 2019 at JAMA Surgery, and basically the Danish group, and they basically concluded that nationwide introduction of MIS robotic surgery for early stage endometrial cancer changed from open surgery to minimal invasive surgery, and that this reduced the risk of complications, and this was due mainly to the use of the robotic surgical platform. So what about the elderly patients? We all have like patients that are older with either endometrial cancer, ovarian cancer, but I think that the growth is like endometrial cancer. So this was also published by my former group at Sloan Kettering. They analyzed 3 groups of patients, 65 to 75 years old, 75 to 84 years old, and over 85. It was almost 1,000 robotic surgeries. 72% had a malignancy diagnosis, and the majority of them was endometrial cancer. And they concluded and they observed that it was safe in elderly patients. And of course, like even in open surgery, there was an increased risk for unfavorable outcomes in the over 85-year-old group. So like we discussed on the last presentation, in the severely obese patients, I think that's when robotic surgery plays a more important role, and especially because these patients usually have like endometrial cancer. So this paper just basically concluded that robotic surgery in obese patients with endometrial cancer is feasible, it's reproducible, and it's a valid alternative to laparoscopy, and it definitely reduces the risk of conversion in these patients. So in terms of like ovarian cancer, I think the evidence is growing. There's a lot of data out there on MIS in selected cases of early stage ovarian cancer, and this data it seems more robust. In the recurrent settings, well, so you have very well established surgeons and surgical departments that do in the recurrent setting for selected patients, and so it's always important to stress that you need well-trained surgeons and well-rounded surgeons to do these particular cases. There's this new trend about robotic surgery and also in the interval cytoreduction setting. Because I do a lot of extensive cytoreductive surgery as well. This kind of scares me a little bit, but the data is out there. So this was published by, I think it's an Italian group, and they did 91 cases, which 57 underwent robotic surgery, 82% of complete gross resection. The length of stay was 1 day. And I think like the most important, the key aspect of this is like you need to highly select the patients that you're going to take to the OR after neoadjuvant chemotherapy. This was another, but on the same setting. I think it was a Chinese group, 93 cases, 43 underwent robotic surgery, and they concluded that the use of robotic surgery did not affect the bulking success or oncologic survival indices. So I'm not going to lose my time to talk about like the LAC trial and the whole cervical cancer and the minimal invasive surgery controversy. Data is out there. I'm not going to talk about it. And we all know what happened after this. So what I'm going to show you here, this is from my previous institution, the Champalimaud Foundation. I just moved to a new hospital, but I also have the XI available. So the main components, like it was discussed before on the S side, so you have like the surgeon console. On your right-hand side, I was lucky because in my former institution, we had a dual console, which is pretty cool to teach younger physicians. And basically what you have is like the 3D viewer, which is great. It's immersive surgery. You have an enhanced vision of anatomy. You had the hand controls, intuitive motion. There's precise, without tremor. At the instruments tips, you have like the like it was said before, the endo wrist. And of course, it's better to spend like a couple of hours sitting very comfortably than like being like standing all the time. So you have like the patient card, and this is the XI, so it's a little bit different from the SI. So you have the boom, which is like the structure that promotes flexibility and that allows you to position like the patient card arms over the surgical workspace. The universal arms, that's when you're gonna insert the endoscope, the instruments, and you're gonna dock the ports. And then you have a touchpad that's not shown here, but enables like everyone to move the patient card and select and adjust the boom height, improving all the setup efficiency. And then you have the vision card. On the vision card, you have like the touchscreen monitor. It's also good because it's high quality, it's HDR, and allows like all the OR staff to adjust vision settings and to troubleshoot stuff when you're sitting on the console. You have the electrosurgical unit, meaning like the generator, the Da Vinci generator for energy settings. And then you have the endoscope controller, where you have like all the stuff related to your camera. And then one amazing thing about like robotic surgery is you have like this plethora of instruments. You have like regular, like you can see on the right side, the monopolar scissors. You have like all your bipolar devices. On the middle picture, you can see like advanced energy devices. You have like this new instrument on your left-hand side. I think it's like the Synchro Seal. This is another advanced energy device. So you have the whole plethora of instruments that you can use. So trocar placement for GYN oncology, it's different from the SI and the XI. So on the XI, you need to use a straight line for port placement, except for the assistant port that should be like 30 degrees cranial to your robotic ports. As per recommendations of Intuitive, it usually should place your ports between 18 to 20 centimeters from the pubic symphysis, meaning just be above the umbilicus. If you're planning to do periaortic lymph node dissection, you should be a little bit closer to the umbilicus, and then you can do a redocking for the upper abdomen. The distance between trocars, it should be between 6 to 10 centimeters, and the recommended distance is 8 centimeters, which basically is like your wrist, your fist, sorry. So what you have here is like a little bit of a drawing showing that for targeted anatomy, you should be a little bit further away from your targeted anatomy, meaning like if you're targeting to do a hysterectomy, you should point the crosshair towards the bladder. This it's almost like, you know, it's academic because the robot is so intelligent that he's going to correct the stuff that us humans that don't do properly. So basically, this is my setting for GYN oncology. What you have here is like a straight line of all the robotic ports. You see like the assistant caudally and cranially. You're going to see the assistant port that it's not on the same straight line. Just to allow for you for your assistant to better help you, because the robotic arms can collide and can just make their life miserable. That's true. So docking, for me, just a couple of pearls that my mentors in the US taught me. So know how to do it yourself. You need to be the most knowledgeable person in the OR for every aspect of every surgery. For GYN docking, you come from the right side of the patient. So it's usually you have like the settings, it's pelvic right. And you should like my previous, like the previous presenter said, strive for have ergonomy in the OR because everything will be more smoothly and the flow will be much faster. So I'm going to show you just this first video. This is I'm sorry for the sound. This is my scrub nurse just trying to start things, meaning she's just like putting all the robotic arms in position. You can see the boom that has like the crosshair on top right here. And so she's just putting the arms on the exact position before she does the docking. So it takes like the time that you're seeing here is exactly like 25 or 30 seconds, and that's it. That's part one. So that's the next video that I'm going to show you here. It's the docking part. So you have the unscrubbed or the circulating nurse just driving the robot by itself to the surgical field. I'm there just like signaling, which is the port that I'm going to introduce the endoscope. So you need the crosshair to be like a little bit on top of that port so the setting is better. And then you're just going to dock first the endoscopic arm, and then you're going to dock the other ones. So in the third video, it's a little bit longer, but this is just because when people talk about robotic surgery, they all say, oh, it adds some more time for in the OR than when compared to laparoscopy. It's true, but it adds, I think, 5 minutes on a well-rounded OR team, familiar with robotic procedures. So here you go. And this one lasts exactly 3 minutes. That's how much it took me for this surgery to have everything ready and just go to the console. So the same, the robot is coming. You see the crosshair on with the right, the green. So I'm just telling them to load the boom a little bit. And I'm just gonna connect like the arm number 2, which is usually the one that you're gonna put the endoscope in. So it's easy peasy. It's nothing much. It's easy. It's done. So I'm introducing like the scope right now, and I'm gonna do like the aiming, which is also nice. Sometimes people when they're like so proficient in robotic surgery, and because yes, we're working in the pelvic cavity, there's nothing much, so they target or they don't target, but targeting makes it more ergonomic. And as you saw, I was pointing towards the bladder and not the uterus. So now I'm docking like the arm where I'm going to put my bipolar on arm number 1. Arm number 3 that my assistant is docking right now, we're going to put like the monopolar scissors. So also the robot is like very smart and he can guide you. You don't need to be like looking to the instrument tip, but it's, of course, it's much better. It's more safe, but you can put it like when you become like familiar with it. And here I'm just pointing the camera to see where I'm going to put my instrument, and you're going to see on that screen that it's coming in. There you go. So I have the monopolar, the bipolar set. What I did now is just like something that's very important. We call it like the burp. So it releases tension of the trocar in the fascia. So now I'm helping my assistant to put like the monopolar scissors. He's docking like the 4th arm where we're going to put the ProGrasp, which is like the retraction instrument. And sometimes it's a little bit more difficult because you have like the other arm connected, but usually it's like pretty straightforward. There you go. So now we're gonna give him like the monopolar scissors, which is gonna go on arm 3. You see the sound, and then you get to push the button that allows you to control the instrument, which is right here, this one. So I'm showing him, and the scissor is in. Now I'm showing him, like, if you see here, that's trocar number 4, and he's going to put the retraction instrument over there. Then you need to guarantee like there's a space between all the arms, so you don't need to scrub in. So you don't need to, this usually takes like 45 minutes to do like a hysterectomy. So it's supposed to be like smooth and fast, and you don't want things like to ruin like how fast it should be going and you should be moving. So right here, I'm just like trying to have a little bit more of space in between my arms. So this was because Dr. Sikam asked me a little bit of like some real life surgery. So I'm just going to show you a little bit of the video. This is like an endometrial cancer video. So I'm just opening spaces and developing. What you can see here, it's that you don't have with straight stick laparoscopies, like this magnified video. So you can see like small blood vessels, you can see structures. To the people that rightfully say that you don't have like the grip feel of touching the instruments like when you're doing minimal invasive surgery. Yeah, but when you become experienced, you know the traction that you should put on tissues, you know exactly what you're grabbing. So you saw the ureter there. So I'm here just finding like the obliterated umbilical, dividing the round ligament. One thing that it's key and it's mandatory when you're doing robotic surgery, even more than in laparoscopy, you need tension. So you need tension. You need to be constantly moving and adapting. If it's the scissor is not cutting, that's because you're not doing tension with both of your retraction arms. So I'm trying to find and develop like the paravesical space. So I found the obliterated umbilical right here. So as you can see, it's precise. So I'm going to have a little bit bleeding here. You can like see it, clean the field, keep your operative field clean. It's especially important when you're doing like sentinel lymph nodes for endometrial cancer. So do some precise dissection so you don't have like all the lymph node channels burst and open, and it's going to be like a mess to try to see where the sentinel lymph node maps. So it's easier, it's faster. Like in the previous presentation, it's you have like a faster learning curve, so it's more democratic robotic surgery. You can start doing procedures way faster, and I think that's one great advantage of it, because if you have more surgeons doing MIS, you're going to have less laparotomies, which is, I think it's the main goal here. So paravesical space developed. So you're going to see here the channel coming from medial to lateral across the obliterated umbilical. That's where you're going to find like 80 to 90% of your sentinel lymph nodes. So it's right over there. So I'm just going to push it a little bit forward so to show you a little bit on this part here. So I think that then you can see again, channel, medial to lateral, and I'm going to have like my sentinel lymph node here, right on the obturator space. Then it's just dissection. I have the lymph node here with me. I'm just going to show you a little bit of the one thing that I forgot to tell you is like, because with the robot, you have like the infrared view on the tip of your finger. So it makes this surgery, I think it makes sense to do robotic endometrial cancer cases with sentinel lymph nodes, because it's so easy. You don't need any extra device, any extra camera. It's all there in the robotic platform. That's it. So dissection, and just taking like the lymph node out. And you're going to see how it looks, and it's done. I'm just going to show you the green part, which I think it's going to come right now. So you can see like this is the correct sentinel lymph node. And there you go. So what has robotic surgery allowed me to do? So I started doing robotic surgery in my fellowship in 2015. So I've done well over 400 procedures, most of them with a diagnosis of malignancy, or at least a frozen section was required. My median length of stay is 1 day, and fortunately I've had no major complications, no takebacks, no conversions. And I think that what allowed me to do is a little bit more of precision medicine, especially in the cases like I've shown you before, like sentinel lymph nodes in endometrial cancer. And I've done like some recurrent ovarian cancers too, well-selected cases with pelvic or one abdominal site for recurrence. So in terms of take-home messages, not to take so much time from you, and so you can have a little bit of discussion. I think robotic surgery is the present and future of MIS. It has a fundamental place in GYN oncology, in endometrial cancer, ovarian cancer. Not going to talk again on cervical cancer in the LAC trial. And like I said before, one thing that I love about robotic surgery is like it's democratic. It has a faster learning curve. You have more surgeons doing MIS, you have less laparotomies, and that's the whole point without compromising, of course, our oncologic outcomes. So just a little talk a little bit more about me. So I also do training of Migo, and we have like this basic robotic skills course. It's in this July. I think it's already sold out, but I'm more than welcome to have like my colleagues from the Philippines. And that's it. And thank you so much for having me here.
Thank you very much for that excellent lecture, Dr. Joao.